I've got a long way from San Francisco. Stanton, not that long. So Jennifer is Medical Center and Clinical Director of Women's Heart Health Clinic. Sorry, not Heart Health, Women's Heart Health at Stanford Clinic. She's an interventional cardiologist as well, with a lot of interest in CTO, in the NOCA and SCAD, and so we're collaborating together. Several of us are working with her group in Stanford on pericardium patients with SCAD, and not only from North America, but also from Europe. Welcome, Jennifer. Welcome back again.
Thank you, Jackie. I appreciate the invitation. I thought to be here. So I'm going to talk about SCAD and its association with pregnancy hormone, or pregnancy as well as hormonal triggers. These are my disclosures, none pertinent to the talk today. I'm only going to spend about one slide on hormonal triggers by themselves. So there's certainly a theoretical basis behind the idea that hormones and pregnancy may be playing a role. So we know that sex hormones can contribute to vascular degeneration. Their progesterone will impair collagen synthesis, and estrogen can cause the release of matrix metalloproteinase, which can induce necrosis to the media and also weaken the vasa vasorum. And there's actually a lot of other physiology behind this, so certainly there's a reason that this could play a role. In terms of most of the hormonal triggers, there's kind of case-based evidence. It's similar to exercise and emotional stress that we just heard about, that at times these things may be coincidental, and at other times they may actually be playing some sort of role. I mean, there's stuff with your menstrual period, and say all the women spend 3/4 of their lives from age about 13 to 50 having, or I say 3/4, a quarter of their lives having, hopefully not 3/4, having a menstrual period, so it's a little hard to say. You know, there was a case report that said, oh, I had SCAD when I was on my period. It's like, well, probably a lot of other things happen. So some of these are hard to sort out. So there is evidence, though, or there is at least association with the menstrual period around the time of perimenopause, concern with hormone-based contraception, hormone therapy for menopausal symptoms, association with infertility treatments, certainly with pregnancy, which is what we'll spend the most time on. Lactation, we all have patients that have had their SCAD event while breastfeeding, and so may also have some sort of role there. Beta HCG was brought up, and there's case reports with anabolic steroids as well. So if we look at SCAD and pregnancy, so overall, MI complicates about 1 in 16,000 pregnancies in the United States, but SCAD actually accounts for over 40% of those MIs that occur in pregnancy and the postpartum period. So it's a very important part of MI for pregnant women. If we look at SCAD events, so kind of the reverse, it's actually only about 15% are pregnancy associated, and I think for a lot of physicians that's a little bit of a surprise, because I think the one thing we were taught in medical school is that SCAD is associated with pregnancy. So people do better if it's a pregnant person having a heart attack, they think about SCAD as opposed to simply a young woman coming in with an MI. They don't always think about SCAD. And the cause is thought to be a combination of hormonal and hemodynamic factors. So these hormonal factors that we kind of already talked about, where there's some degeneration of the vascular wall, certainly can play a role. And then hemodynamic factors, certainly we know that cardiac output goes up significantly, the body's working much harder during pregnancy, and then the act of delivery and sheer stress that may be going on may also play a role. And these changes that we see in terms of the hormonal changes to physiology can persist for quite some time, and maybe even longer if you're continuing to breastfeed. So if we look at pregnancy-associated SCAD versus non-pregnancy-associated SCAD, I'm going to focus on two studies. Both came out very close together in 2017. There are other studies out there, but this is the two I was going to focus on. And the USC study actually is incorporating many of the studies that were out there because their data came from published cases. So the other group is from the Mayo that published their work. So the USC group has had 120 cases. They did not have any controls that they looked at from their own group, but they took basically published controls without pregnancy-associated SCAD from Mayo and Vancouver publications to compare. And they looked at 113 published cases that came out between 2000 and 2015. And they included women up to 210 days after their delivery. The Mayo group published 54 cases and had 269 controls, and that was drawn from their registry between 2011 and 2016, and they defined postpartum as 12 weeks after delivery. So this is kind of a compilation of those studies. So if we compare pregnancy-associated versus non-pregnancy-associated SCAD, we don't see any significant differences in cardiac risk factors between these two groups. Pregnancy-associated SCAD patients are younger. They have a mean age of 33 to 35, whereas the non-pregnancy-associated SCAD patients' mean age is 44 to 55. Notably, while these pregnancy-associated SCAD patients are younger, they're younger than the non-pregnancy-associated. They're actually older than a typical pregnant female whose mean age is 27.6. These pregnancy-associated SCAD patients are also older at the time of first childbirth, so 46% of them over the age of 30. And they're often multiparous, so they've had several childbirths, 91% versus 76% in the non-pregnancy-associated SCAD, and both higher than just the general population, where you see 64%. And this is felt to be pertinent in that maybe having more children, you kind of accumulate this vascular degeneration each time you have a baby, and that actually makes it more likely that eventually you're going to have a SCAD event. You also see more preeclampsia in the pregnancy-associated SCAD patients, 11%. It wasn't significantly different than non-pregnancy-associated, but higher than we would see in the general population, where preeclampsia is about 3.5%. There's also a trend towards seeing more infertility treatments in these patients, where the pregnancy-associated had 28% of them, some sort of infertility treatment, whereas the general population, 12%. And then we, as mentioned, see the onset during or shortly after lactation. That's been at around 11%, and interestingly less FMD in pregnancy-associated SCAD patients, 42% versus 64%. So again, suggesting that perhaps here you don't need necessarily another underlying etiology, and that pregnancy itself is causing the problem. So when do these events occur? So the majority of them are in the postpartum time frame, so about 70% of them. You don't see many in the early time frame, and you don't see that many actually at the time of delivery, which would again suggest that perhaps this Valsalva or extreme stress on the body is actually not really the problem, and again, it's more the hormonal milieu. When it does occur in the postpartum period, it tends to be early, so first month, and actually in the first week, so the median time period is within 5 days. If you look at the presentation of these patients, they seem to be presenting more severely compared to the non-pregnancy associated SCAD. So all patients have come in with an MI. So either an NSTEMI or a STEMI. And STEMIs actually are 60 to 75% of those patients. And STEMI is always a more significant presentation. Their ejection fraction is lower at the time of presentation, so 40 to 46% versus 52 to 56% in the non-pregnancy associated SCAD. And 44% have an EF less than 40%, and 26% with an EF less than 35%. You also see more multi-vessel SCAD, you see more left main involvement, and you see more proximal artery involvement. The significantly higher complication rate that is listed here, so this is from the USC group. I think it's important to note that, again, they pulled their data from published articles, and so published articles usually are a little bit more fantastic than non-published articles, because you have to have something interesting. So it may be that these patients look really sick because that was what would get published, and if you do really well, nobody cares. So in their cohort, cardiogenic shock and need for mechanical support in about a quarter of patients. And compared to non-pregnancy related SCAD patients, we see that in about 1%, so certainly not the same rate. VF required defibrillation, 16%. They had an in-hospital mortality of 4%. The Mayo group had no in-hospital mortality, and there was fetal mortality in 3 of their patients. These were all women that presented with buccal dissections. So if we look at how these patients are treated, this table is actually kind of nice. It was in an editorial. So the first column is the USC group, and then the second column is the Mayo group. So those are the 2 groups we've been talking about, pregnancy-associated SCAD, and then non-pregnancy-associated SCAD is a Mayo cohort and then Vancouver cohort. And so you'll see what I've already been talking about, that the females in the pregnancy-associated SCAD are younger, more STEMI, more left main, more LED, more multi-vessel, lower EF when they come in. We talked about mortality. In terms of treatment, there's actually higher rates of CABG in the pregnancy-associated SCAD. There's higher rates of unsuccessful PCI. Conservative management is lower in those groups, and again, some of this may be biased by these ones that were published. Conservative management wouldn't be as interesting to publish. However, lower rates of conservative management, and then there are higher rates of failure of that conservative management, and the patients had to go back to the cath lab or have some kind of revascularization. There's also data suggesting that the angiographic healing of these vessels may be lower. So we typically will see healing 70 some to 90% of patients, and here about 65% of patients. The recurrence rate, we haven't seen any differences between pregnancy-associated and non-pregnancy-associated SCAD. So recommendations that are given at this time, if a patient comes in who's pregnant and having an MI, there's no reason to not go to the cath lab out of concern of radiation. The amount that a fetus gets is incredibly low in the cath lab, and is unlikely to reach levels where it's going to be detrimental, particularly with using methods to reduce radiation. And if the mother is postpartum and gets iodine, she can still continue to breastfeed. And most of the cardiac drugs that we use in SCAD are safe during pregnancy and lactation. There are some exceptions. So statins we don't give in either case, and ACE inhibitors we don't give. Plavix you would avoid with lactation, and usually if you're giving aspirin, you want to wait a couple hours before breastfeeding. In general, we give a recommendation of avoiding hormonal-based contraception and postmenopausal therapy in patients who have had a SCAD event. And so there should be a discussion about how you avoid getting pregnant. So vasectomy or tubal ligation are things that are discussed. IUDs are another thing. So Mirena is a progesterone-based IUD. And then there's a copper IUD, which doesn't have any hormones. The progesterone IUD does help if there's heavy bleeding. And while both are very effective, the copper one may be slightly less effective. But again, things to have discussions about. I think it's really nice if you're at a place where you also have somebody in OB to kind of help reiterate these points. And then for females postmenopausal, locally applied vaginal estrogen is generally considered to be safe. So what about having a baby after having a SCAD event? This is a serious and big discussion for people to have. We really don't have a lot of data. So the Mayo Clinic published a series of 8 women out of 363 who had pregnancy after SCAD, and only 1 of the 8 had an event. It was at 9 weeks postpartum and needed an emergent CABG because of the failed PCI. general, we don't advise it, just because, again, it's a potential risk for having a SCAD event, but the data is limited. Surrogacy is something that is often talked about. If a woman does decide that she'd like to proceed with pregnancy, we usually advise that you wait at least a year after the SCAD event. I think a team needs to be in place for high-risk pregnancy with very close follow-up. And in terms of the pregnancy itself, an epidural is often considered to be done. And then having a vaginal delivery where you try to minimize Valsalva, an operative vaginal delivery, and C-section are options. So in the last figure, I just wanted to highlight a collaborative study that many of us in the room are participating in. This is, to my knowledge, I think this is the first collaborative international study in SCAD. So we're really happy that this is going on, and it's looking at angiographic and psychosocial issues for pregnancy-associated versus non-pregnancy associated SCAD. We have 4 places in the United States and then 3 outside the United States. And basically looking at the same things we've been talking about, the non-pregnancy associated SCAD patients are age matched. I think the highlight again is that we were kind of finally getting people together and collaborating and putting their work together, which is definitely going to give us a new view as opposed to having individual sites or case reports as we've had in the past. So we're going to look at differences in presentation. There are 4 labs doing PCA and angiographic analyses. We're looking at in-hospital management, the outcome of these patients, and then psychosocial variables, pre and post-SCAD, including PTSD. So the initial findings that we have are mostly similar to what has been out there. So there's more multiparity in these pregnancy-associated SCADs. We are not seeing any difference in FMD, but I would say that we are getting FMD data from chart reviews only, and not all institutions have kind of a set system of analyzing or testing for FMD. We're also seeing more multi-vessel and left-wing SCAD, as has been seen before. Interestingly, however, not necessarily seeing a lower EF or higher troponin bump in those with pregnancy versus those without. And no difference in SCAD recurrence, as other studies have not seen that either. So we're also not seeing any difference in the incidence of MACE, and these patients are being followed out several years. The median follow-up is 2 years, and the maximum follow-up is 10 years. And no difference in cardiovascular rehospitalization for these patients, although there is a deviation of those lines, but that's at 5 years out, and no difference in SCAD recurrence, as I already mentioned. When you look at the psychosocial outcomes, which I think are important, we're hearing more about this, and Dr. Pittman-Wagers is here and is going to talk to you, and I will highlight Katie Edwards from Stanford. Those 2 psychologists have really contributed a lot to this area. And when we look at differences in just kind of baseline anxiety, depression, PTSD, and perceived stress between pregnancy-associated and non-pregnancy-associated SCAD, we don't see any differences necessarily before or after, which kind of surprised me because I thought, oh, it would be more traumatic to have this happen when you're having a baby, but I'm not sure if maybe they're so distracted and stressed by the baby that this doesn't seem like a big deal. I'm not sure. But when we look at basically these distress measures and what they're associated with, certainly they were associated with unemployment, which probably, I don't know if it has anything to do with SCAD, but also having a prior psych history, and then patients with rehospitalization and recurrence, which I think makes a lot of sense. So in summary, about 30% of SCAD patients will have events associated with possible hormonal triggers. A good bit of those are going to be pregnancy, but others are going to be potentially on hormones or had fertility treatments, etc., that may or may not have played a role. And pregnancy-associated SCAD appears to be more severe in its presentation, and it often requires a multidisciplinary team for management. And the treatment is similar between the 2. So patient any differently than the non-pregnant patient, with the exception of some of the medications which need to be considered. And then for any SCAD patient, future hormonal triggers are best avoided, but I think that you have to individualize these and have discussions, because sometimes people maybe can't live without their hormones or really want to have a baby, and that's important to discuss. So thank you very much.